Three. A very good afternoon and welcome to the sessions on recurrent miscarriages, causes, and treatments. We are glad to have Dr. Ramyasree Reddy among us today to help us understand the topic. Many women have a miscarriage at one or another time. Miscarriages can happen for many reasons. There can be different reasons for that. And to help that understand better, our doctor will discuss this topic briefly and will take us through and more into this session. Doctor, you have the stage now.
Good afternoon, everyone. This is Dr. Ramyasree Reddy. I'm a consultant fertility specialist at Apollo Fertility, Nagar, Chennai. Welcome to this Facebook Live. Today we'll be talking about recurrent miscarriages. Before we understand the topic proper, let us understand when do we call a pregnancy a miscarriage. So, whenever there's a pregnant woman undergoing spontaneous demise of pregnancy before the period of 24 weeks of gestation, that is somewhere around the fifth month, before that, we call it a miscarriage or a pregnancy loss. This, if it happens more than once, then that would be called considered under frequently happening miscarriages. And when they happen more than two times, we would call them as recurrent miscarriages. Now, you would ask me, why is the number two more important? We need to understand that with each pregnancy loss or miscarriage happening, the risk for the next subsequent pregnancy to go into a miscarriage also goes higher. Along with the maternal age, that is the mother's age, the previous history of obstetric history, wherein the number of miscarriages are there, that becomes a significant risk factor to understand how the next pregnancy goes. To help you understand this better, I'll give you a few numbers. Let us say a woman who is pregnant for the first time. That means there is no abortion history in the past. Her chance of having a miscarriage would be as minimal as 12%. And a woman with one miscarriage in the past runs a higher risk, something around 24%, that is double the risk. And a woman with more than six miscarriages, she has almost 50% chance of undergoing a miscarriage in the subsequent pregnancy. So in this context, it becomes important for us to understand how many number of miscarriages after do we need to seriously look into this matter and work up, because this is an increasing burden and it's also associated with a lot of emotional trauma to the couple and entire family. So, to understand this, let's first talk about what are the risk factors. We can group these risk factors into a few categories. One, like we already discussed, the maternal age, the previous obstetric history. Apart from this, there are some genetic factors that we need to look into. Then there are some criteria called thrombophilia. Then there are infective causes for this. Then there are anatomical causes, endocrine and metabolic causes, and not to forget, there is a male factor also which needs to be looked into. So, how do we understand what age is ideal and carries the least miscarriage risk? So, a woman in the age group of 20 to 25 is supposed to carry the least risk of having a miscarriage, that is around 11%. And above this, it slowly starts to increase, going up to 15% in the age of 30 to 35 years. And a woman above the age of 40 to 44 has a risk of 50% for having a miscarriage. So now we have understood there is a risk of age, increasing age causing miscarriages, and past history of having miscarriages, both having an impact on what happens into your next pregnancy. Then people will ask generally, is there any effect of the lifestyle factors that we have? Lifestyle factors being either there is a smoking history or an intake of alcohol or somebody with obesity. Yes, these all also have a risk of increasing your miscarriage percentage. If you talk about numbers, smoking, as much as one smoking per day, we say has a relative risk of 1% increase in your general inherent risk of an abortion. Let us say somebody in the age group, like we have previously discussed, 20 to 25, has an inherent risk of 12%. And with each cigarette taken per day, 1% risk increases, right? So this is understood. Then what about obesity? Obesity also has an impact in causing a miscarriage, and there is chance that it can recurrently happen. And there are also studies which say that intake of more than 3 cups of coffee also has a bearing about the miscarriages. Now, let's talk about genetic factors. What happens in genetic factors is when we talk about miscarriages, let's understand how the pregnancy can be discussed. The first 3 months of pregnancy are called the first trimester, next 3 months are the second trimester, and the last 3 months we would like to call it as a third trimester. Now, whenever we see miscarriages happening in the first trimester, that is the first 3 months, more often, something around 50% of the times, the cause for the miscarriage would be a genetic factor. So, you need to understand 50% is a relatively huge burden. So, why is this happening? What we need to understand is Mother Nature has a natural system wherein there is filtration happening of the genetic material of the embryos which are not compatible with life. So, when there is a unrecognized pregnancy loss, which we call as in even before the mother knows that she is pregnant, there are a lot of pregnancy losses which happen, a lot of miscarriages. These are not calculated in the percentages because nobody is even aware that the lady is pregnant. These undergo spontaneous termination because they are not compatible with life. And just after understanding that somebody is pregnant in the next 2 3 weeks, when there are some miscarriages happening, we need to understand these also come in the same category of the chromosomal abnormalities leading to miscarriages. And when do these happen? So, with increasing age of the mother, there is more and more chromosomal abnormality happening and noticed in the eggs that are produced. And the same genetic material is passed on to the embryo. And so, with the increasing age of the mother and father both, there is increased chromosomal abnormalities noted in the embryo, which leads to more chances of abortions. And when you look at the percentage of people having this recurrent miscarriages more than 2 times, we often find that around 2 to 5% of people have some or the other balanced chromosomal abnormality. So, how do we understand what to do in this kind of cases? Whenever there is a spontaneous miscarriage and it's happening more than once, it becomes important for us to send the pregnancy tissue for karyotyping. Karyotyping is genetic testing of the genomic material in that pregnancy tissue. And apart from this, we also would like to look at the couple, the husband and wife, both their karyotypings to understand if there is any balance, translocation, or any other genetic issue going on there. Now, let's talk about the next set of factors, that is thrombophilia. Thrombophilia are nothing but a sort of blood disorders wherein some of them are hereditary and some are acquired. In hereditary category, we would like to talk about protein C, protein S, antithrombin, these deficiencies. And these are to be tested whenever there is a woman having additional risk factors for thrombophilia. Now, talking about acquired thrombophilia is the most often talked about one is APLA syndrome or antiphospholipid antibody syndrome. Why is this very important? Whenever we see the recurrent pregnancy loss population, when we look at them as a whole, around 3 to 5% of them are affected with APLA. And the best thing about understanding that somebody is APLA positive is we can treat it. It is potentially treatable and preventable cause. So, very important to identify when somebody is positive with APLA. And how do we do it? We look for certain blood tests in which we look for lupus anticoagulant antibodies or anti-beta 2 glycoprotein or anti-cardiolipin antibodies. Next, the next chunk of factors that we can talk about are metabolic or endocrine factors. Here we need to look at thyroid. In thyroid, whenever there is thyroid antibody increase, we need to understand that it has an effect on the folliculogenesis, fertilization, and embryogenesis. So, whenever there is a woman presenting with higher TSH levels, we need to understand if there are any autoantibodies of thyroid present, and that needs to be addressed. And if required, levothyroxine supplementation would also be required. Then another thing to look for in metabolic factors is vitamin D. Vitamin D deficiency is routinely seen in a lot of Indian women, more so with our lifestyle habits. And it is very important to consider supplementing vitamin D in all pregnant women, not just in RPL cases. Then the next chunk of causes for the recurrent miscarriages would be the anatomical causes. The anatomical causes being the abnormalities either in the uterus or in the cervix. In uterus, there are two kinds of anomalies that we can talk about. One which are congenital, that means something that is that the woman is born with. So I'll just show you a picture to understand the same better. So this is the normal uterus. Here, if you can see, this is the uterine cavity which is intact. There are certain kinds of uterine anomalies wherein there is a septum here, a thin line which is there here, which is separating the uterus into two separate portions. In that case, we call it a septate uterus. Or when there is a notching in the upper surface leading to small cavity, which we call an arcuate uterus. Or we can also talk about something called a biconvert uterus, wherein this cavity is totally cut off from this. It's like two different cavities are present. These are the congenital uterine anomalies that can be present, and these have a bearing and they are known to cause first and second trimester miscarriages, more often in the second trimester. And along with this, there are other obstetric complications that can happen, like in cases of arcuate uterus, etc., wherein there is preterm pregnancy, malpresentations, and there could be a more cesarean delivery or instrumental delivery happening. Then, apart from this, let's talk about the acquired causes. In acquired causes, we need to talk about uh, cervical insufficiencies, polyps, and intrauterine adhesions. Intrauterine adhesions are when there are adhesions inside the uterine cavity, and apart from that, there can be some polyps which are inside the uterine cavity. Though not seen very often, it is important that if there is more than 1 centimeter size polyp in the endometrial cavity, that needs to be looked into deeply. And then another important chunk is uterine fibroids. These uterine fibroids, depending upon their location, whether they are inside the cavity, they are affecting the cavity or not, they have a significance on whether a recurrent pregnancy loss can be caused. Then, apart from this, we discussed that there can be cervical changes also. Cervix being the opening of the uterus, how can that affect? We need to understand that when there is a woman having repeated second trimester abortions, we need to look into how the cervix is performing. So there can be chances that a woman comes to you with history saying she had sudden leaking of liquor, as in there was some uh, water that has started to leak, and she has had some bleeding, and she lost the pregnancy. This happened around fourth to fifth month, and this has happened more than once in her obstetric history. So we need to understand it is the cervix that is giving away mid pregnancy, and that is leading to this problem of recurrent pregnancy losses. But how do we understand for sure diagnostically? There is no objective method to understand this. There are different tests that are performed. In the inter-pregnancy interval, there is no objective method to diagnose for sure as this. The best way to diagnose this is through the history, that there is spontaneous rupture of membranes or there is painless recurrent second trimester abortions. Now, let us talk about the diagnostic modality in which we can understand better if there are any anatomical abnormalities. The best possible thing that can be offered is a 3D ultrasound, which is very much available with every center these days. A transvaginal 3D ultrasound is sufficient for us to understand if there is any septate uterus, arcuate uterus, or if there is any biconvert uterus. These things can be identified. In rare settings wherein a 3D ultrasound is not possible, we will need to ask for an MRI. And then let's talk about male factor. Male factor, this is very important in this scenario of recurrent pregnancy loss, because with all these factors and explanations done, there is as much as 40 to 50% that is still unexplained and uncategorized as what is the exact cause for the recurrent pregnancy loss in this particular case. In those cases, male factor becomes very important. And in male factor, what exactly do we need to look into is the sperm quality, the lifestyle, and if there is any alcohol intake, smoking, anything that is being taken by the male partner. And there is a factor of sperm DNA fragmentation which needs to be checked, because sperm integrity is very essential for the sperm and egg interactions, fertilization, and the early embryonic development. And there are many studies which say that sperm DNA fragmentation has been the cause identified in many unexplained RPL cases. Now that we have understood all the causes for the recurrent pregnancy loss, we need to understand how do we manage it. So let us talk about each cause and how do we manage that. Starting first with the genetic background. With the genetic background, we have understood that when we see that there is repeated miscarriage happening, we need to send the pregnancy tissue and we need to get the mother and father tested for their karyotypes. Apart from this, we also have something called pre-genetic testing. This is where when we do an IVF and we take the trophectoderm, that is the outer part of the embryo, for a biopsy through laser assisted procedure, biopsy is done and these cells are sent for testing. This is called pre implantation genetic testing. And with the help of this, we can understand what is the genetic makeup of the embryo. This is one of the advanced techniques, and there are many studies going on saying what is the benefit of this, and the studies are both equivocal. Some saying there is benefit of doing them, and some saying there is no benefit. But that is one new tool in our armamentarium that we need to keep in mind. Now, apart from the genetic thing, let us talk about thrombophilias. In thrombophilias, we need to understand that there is the options of treatment that we have are heparin. So, with the use of heparin therapy, there is improvement in live birth rate, but bringing down the miscarriage rate has not seen very often in the cases of inherited thrombophilias. But when we talk about acquired thrombophilias like APLA syndrome, it is very important to start prophylactic aspirin and heparin, and they are known and they have shown and have been recommended by ESHRE to bring down the rate of miscarriages. Then the next topic of discussion would be the metabolic or endocrinological abnormalities. So, how do we treat these? Once we have identified that a woman is overtly hypothyroid, even before pregnancy, we need to start supplementing her with levothyroxine. That is simple. Now comes the complicated case of subclinical hypothyroidism, where you see there will be autoantibodies coming as positive thyroid antibodies. Now, in these women, if we see RPL, we need to keep in mind that as soon as she gets pregnant, we need to test her thyroid TSH levels, and if we find them to be low, we need to start levothyroxine. Apart from this, there is a case of luteal phase insufficiency which happens, wherein we can supplement it with HCG and we can give progesterone, either vaginal or by whichever route that you have chosen, and that is shown to bring down the miscarriage rate as shown in the PROMISE trial. Now, talking about the anatomical causes. So, as we discussed previously, there are congenital and acquired causes. And for the congenital causes, once we have identified that it is an arcuate uterus or a septate uterus, once we know for sure that the cause for the miscarriage, there is nothing else except for that septum or that arcuate or biconate uterus, there is no added benefit of doing a metroplasty. This is what various studies say. So once you rule out every other factor, every other cause for the recurrent miscarriages, and you can only come up with either a fibroid or a septum, only then go in and do the surgery and take care of them. And in case of polyps, a polyp with size more than 1 centimeter, hysteroscopic removal of them is known to have benefit. Now, talking about fibroids, like we have previously discussed, there are two kinds of fibroids. One which have a bearing on the uterine cavity, that is this part inside. So, the fibroids which are happening in this part, or fibroids which are here but seem to encroach upon the cavity, intramural encroaching into the uterine cavity. These two are the cavity distorting type of fibroids, and these need to be taken care by a hysteroscopic myomectomy. And this has an impact in bringing down the early pregnancy loss. And talking about the non cavity distorting types, which are either subserosal or intramural, not involving the cavity, there is no significant benefit of doing a myomectomy for them. And what about the cervical insufficiency that we talked about? Once we have a typical history that there is recurrent painless second trimester abortions happening, we need to start looking at the woman and checking her cervical length as early as second trimester onwards. And whenever there is a suspected cervical weakness, continuous surveillance, as in once every 2 weekly, has to happen. And if there is any cervical shortening detected, a cerclage has to be considered immediately. Then, now coming to the chunk of Immunological causes. In immunological causes, the place where these come into role is in unexplained RPL. With all these causes looked into, like I said before, around 40 to 50% is still in the unexplained category. And in these unexplained category of RPL, it is important that we empathize to the patients and explain to them that there is a successful pregnancy chance in the future that can be up to 50 to 60% depending upon the maternal age and parity. So there is nothing that can replace an empathetic role of a doctor and the supportive care that can be given by the doctor. Then, what are the immunological treatments, the immunotherapy modalities that we have with us? Usage of intravenous immunoglobulins, intralipids, lymphocyte immunotherapies, giving granulocyte CSF factors intrauterine, or TNF alpha inhibitors, or giving glucocorticoids. These are the immunotherapy options that are available with us, and these need to be carefully considered before starting them because each one of them come with their own limitations and advantages. And last thing, without forgetting, we need to talk about the infections. Usually, in cases of sporadic miscarriage, when vaginal flora and cervical cultures were done, they have identified that ureoplasma, mycoplasma, toxoplasma, rubella, cytomegalovirus, these were the infections that were found. But there is no convincing data that these torch infections are causing recurrent pregnancy loss. So, routinely screening for torch is to be abandoned as per the RCOG guidelines. So, now coming to the take home message, what we need to understand is that recurrent pregnancy loss is an important reproductive health issue. We need to do a full, thorough workup once we identify a couple having two consecutive or non consecutive pregnancy losses. We need to understand what are the treatable causes here and look for them, suggest them any lifestyle modifications, and also explain to them that more than half of the cases are usually unexplained and regardless of the cause. A thorough follow up and important psychological support. This from the patient, from the caregivers and towards the patient, will improve the chances manyfold. And when it comes to what are the important investigations, just doing a quick roundup for karyotyping, then checking for lupus anticoagulant, anticardiolipin antibodies, or anti beta 2 glycoprotein, then a good 3D ultrasound to identify the uterine anomalies, then doing thyroid testing, TSH, and anti TPO antibodies, prolactin levels, a simple glucose tolerance test, then checking for the male DFI. These are very important investigations and not to be missed for. And what are the treatments that have been proven? Anticoagulation, progesterone and HCG supplementation. These are proven modalities of treatment, and IVIG and immunomodulators are potentially promising treatments. These are various things in our armamentarium. And before we wind up this session, I would like to say that this is very big and significant problem, and with the help and seeking care at the right time, not waiting for more and more miscarriages to happen, seeking care at the right time, finding your caregiver who is supportive will have a lot of impact and help out in the right ways. Thank you. Yes, there is a question here asked: does diabetes and hypertension cause miscarriage? Yes, this also comes under the lifestyle factors. There is chance that if there is severe uncontrolled diabetes, there is chance that you'll undergo miscarriage. That is why if there is a known diabetic who has conceived, it is important for us to test for something called HbA1c. When we check for HbA1c, when the levels are much higher, not just the risk of miscarriage, risk of multiple anomalies in the fetus is high. And when these levels are not controlled, repeated miscarriages are known to happen, and it is a cause for recurrent miscarriage. Yes. So that's about it. Hope you have understood about recurrent miscarriages, causes, and treatments. If any further queries are there, you can always reach out to us at Apollo Fertility. Thank you.